Okay, it's CVID. This patient with recurrent sinus and ear infection has low immunoglobulin level and a decreased antibody response to vaccines. These findings are concerning for a primary humoral immunodeficiency such as common variable immunodeficiency disease caused by impaired differentiation of the B cell into plasma cell, which results in decreased production of various immunoglobulin. CVID presents in early adulthood age 20 to 40 or adolescent around puberty with recurrent sinopulmonary infection, typically caused by encapsulated bacteria, Streptococcus pneumoniae, Haemophilus influenzae. Because antibody opsonization is required for clearance of this organism, recurrent gastrointestinal infection, Salmonella, Campylobacter, Giardia can also occur due to low IgA level. In addition, patients may have associated atopic asthma, eczema, and autoimmune rheumatoid arthritis or condition. Immunoglobulin profile in CVID reveals low immunoglobulin profile in CVID reveals low IgG as well as low IgA and or M. Antibody response to vaccine titers are low. Complete blood count would show a normal amount of white blood cell, and treatment is immunoglobulin replacement therapy. Okay. This patient developed fever, arthalgia, urticarial rash. This patient developed fever, arthalgia, urticarial rash, and mild proteinuria while taking chimeric monoclonal antibody infliximab. Chimeric and humanized monoclonal antibodies contain foreign protein derived from other animals and mice. Exposure to foreign protein triggers an adaptive immune response marked by the generation of higher affinity antibodies. Binding of the affinity antibody to foreign protein. Binding of the affinity antibody to foreign portion of the medication generates immune complex which are subsequently cleared by mononuclear cell in the reticuloendothelial system. Although the formation and the removal of immune complex often proceeds without symptoms, large quantities of immune complex can saturate the phagocytic system and can lead to immune complex aggregation. The aggregated immune complex can lead to deposit into the tissue, skin, joints, glomeruli, activate the classic component system, and can cause type 3 hypersensitivity reaction, serum sickness. Common manifestation include fever, arterial rash, arthalgia, mild proteinuria. These symptoms resolve spontaneously as the immune complex are cleared by patients and may develop recurrent symptoms 5 to 14 days after each dose of the medication. In addition to monoclonal antibody, antitoxin, antivenom, or antigenic vaccine can cause serum sickness reaction. Some antibiotics, penicillin, can cause serum sickness-like reaction that is not due to high immune complex titer. Okay, premature infants are at risk of complication. Premature infants are at risk of complication from vaccine preventable diseases. Vaccine preventable diseases due to immature immune system vaccines from preterm infant vaccines from preterm infants should not be delayed. They are safe and not they are safe and proven to induce an adequate antibody response to confer immunity. In addition, mild intercurrent illness is not an contraindication to vaccine. Therefore, medically stable premature infants should receive routine immunization on the same schedule as full-term infants their chronological based on their chronological age. The patient's chronological age is 6 weeks, so he should receive hepatitis B, rotavirus, tetanus, diphtheria, acellular pertussis, Haemophilus influenza type B, pneumococcal, and inactivated polio vaccine at 2 months chronological age. Okay. Yes. Standard pediatric immunization in the US, inactivated polio, inactivated or killed is hepatitis A, polio, hepatitis A, and influenza. And toxoid is diphtheria and tetanus toxoid. Live attenuated is rota, measles, mumps, rubella, and varicella. And subunit or conjugated vaccinated hepatitis B, part 2 C, hepatitis B, part 6, Haemophilus influenza type A, pneumococcal and meningococcal, and human papillomavirus. Okay. Okay. Mm, this patient with chronic pain and altered mental status, hypotension, signs of anticholinergic toxicity, and prolonged QRS interval. These clinical feature prolonged clinical feature, prolonged QRS interval. These clinical features suggest tricyclic antidepressant poisoning. Mm, TCA are frequently prescribed for migraine prophylaxis. TCA are frequently migraine prophylaxis. TCA exert their antidepressant effect by inhibiting the presynaptic reuptake. However, they interact with multiple other receptors. Leading to characteristic manifestation of TSA overdose. In addition, TCA can block cardiac fast sodium channel. TCA can block a cardiac fast sodium channel, resulting in conduction abnormality, QRS and Q2 prolongation, resulting in Q2 and QRS prolongation, which can lead to fatal arrhythmia, ventricular tachycardia, ventricular fibrillation. Management of TCA poisoning includes supportive care, telemonitoring, IV fluid, benzodiazepine if occurs. In addition, when QRS interval more than 100 milliseconds, as in this patient, IV sodium bicarbonate should be given to shorten the QRS interval and reduce the risk of fetal arrhythmia. Sodium bicarbonate uh, Sodium bicarbonate alkalizes the plasma, which favors the non-ionized neutral form of the drug and makes it less accessible to bind to sodium channel. It also increases the extracellular sodium concentration, overcome the sodium channel blockade, which helps overcome the sodium channel blockade induced by TC. Okay. What is the problem in here? He does not have acute problem. No, no, reassure may not be the. I don't think so. It is buprenorphine, isn't it? It's opioid withdrawal. Okay, this patient with evidence of IV drug use, needle mark initially had upper extremity cellulitis. Needle mark initially had upper extremity cellulitis, which appears to respond appropriately to clindamycin as noted by improved local pain and swelling and resolution of leukocytosis. Patient, however, her new symptoms suggest that she is experiencing acute opioid withdrawal. Patients with acute opioid dependence typically develop withdrawal symptom within 4 to 12 hours of the last dose of a short-acting opioid, with a peak 24 to 48 hours after symptom onset. Manifestation frequently include nausea, vomiting, cramps, diarrhea, restlessness, rhinorrhea, lacrimation, myalgia, and arthalgia. Examination examination can show hypertension, tachycardia, mydriasis, piloerection, hyperactive bowel. Some diagnosis is made based on history and examination findings alone. Treatment options include buprenorphine partial agonist or low-dose methadone. Buprenorphine partial agonist and low-dose methanol long-acting full agonist. Adjunctive medication may also be given. Adjunctive medication may also be given for symptom relief. These may include loperamide, diarrhea, ibuprofen, myalgia, baclofen, muscle spasm, and clonidine, anxiety, restlessness, and hypertension. Okay. Yes, opioid withdrawal is 4 to 48 hours after opioid cessation. 4 to 48 hours after opioid cessation. Immediately after opioid antagonist. Immediately after opioid antagonist, life-threatening. Gastrointestinal nausea, vomiting, cramping, nausea, vomiting, cramping, diarrhea, and increased bowel sound, and cardiac, increased pulse, increased blood pressure, and diaphoresis, psychologic, insomnia, yawning, and diaphoretic mood. Other is myalgia, arthalgia, mydriasis, lacrimation, rhinorrhea, piloerection, and history and examination alone, clinical diagnosis and management is opioid agonist, methadone or buprenorphine. Non-opioid is clonidine or adjunctive medication, antiemetic, antidiarrheal, and benzodiazepines. Okay. Yes. 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 Okay. This patient with evidence of acute pneumonia, cough, shortness of breath, leukocytosis, right lower lobe infiltrate, and recent history of recurrent pneumonia, sinusitis, and bloody diarrhea likely has CVID, common variable immunodeficiency disease. Common variable immunodeficiency disease is a collective diagnosis that includes a number of genetic defects. That includes a number of genetic defects resulting from impaired B cell differentiation and hypogammaglobulinemia. Common variable immunodeficiency disease is one of the most common primary immunodeficiencies in adult and is characterized mainly by increased susceptibility to bacterial infection, recurrent respiratory infection, pneumonia, sinusitis, otitis media, and GI infection. Salmonella, Campylobacter are common, and the latter may lead to episodes of bloody diarrhea. Chronic giardiasis Chronic giardiasis may occur, but opportunistic infection, Candida, pneumocystis zerovich are rare. Other characteristics of CVID include concomitant autoimmune disease, hemolytic anemia, rheumatoid arthritis, pernicious anemia, inflammatory bowel-like disease, granuloma development, and increased risk for Hodgkin lymphoma. Enteropathy, sprue-like illness is common, and affected patient may present with malabsorption and weight loss. Most cases of CVID are due to sporadic mutation, and family history of the disease is typically absent as in this patient. The majority of the patients are diagnosed in adulthood, 10, 20 to 45, due to combination of variable presentation and diagnostic delay. The diagnosis is made by quantitative measurement of immunoglobulin level, significantly reduced serum IgG with low levels of IgA and IgM, as well as markedly reduced or absent immune response to vaccination. Okay. Cystic fibrosis, you are thinking. In cystic fibrosis, there is recurrent pneumonia, sinusitis, but it is often diagnosed prior to adulthood, and this patient's CVID is diagnosed. Cystic fibrosis can be diagnosed early, and in addition, although diarrhea and malabsorption may be seen due to pancreatic insufficiency, which is not present in common variable immunodeficiency disease. Immunodeficiency diseases are very atypical, like it is diagnosed after persistent admission of the patient, and if the patient does not admit, uh, like in the children, like primary immunodeficiency disease, and that I'm talking about, very atypical very tough to diagnose as far I think. Okay. What happened to your eosinophil? Okay, now it fixed. Yes, yes, I thought that that the story is beginning. The thing happened the last time. Is it anaphylaxis? Because he has tightness in the chest, like respiratory problem, and swelling, conjunctival erythema. So it may be due to mast cell activation. Okay. This patient with sudden onset periorbital swelling, trunk, wheals, throat tightness, and crampy abdominal pain has anaphylaxis, which may be diagnosed when acute allergic symptoms are present. When acute allergic symptoms are present in more than two organs, skin, mucosa, and gastrointestinal after allergen exposure. In this patient, the probable allergen. In this patient, the probable allergen is amoxicillin. Prior administration likely initiated production of amoxicillin specific IgE without causing allergic response. No known drug allergy. Subsequent re-exposure today then caused mast cell activation and degranulation with the release of chemical mediator histamine, prostaglandin, and leukotrienes. Okay, you take your call because it may be emergency. I don't know. We don't know actually. Okay, okay, okay. Subsequent re-exposure then caused by mast cell activation. Mm, mast cell activation, and degranulation with the release of chemical mediator histamine, prostaglandin, and leukotrienes. The widespread release of chemical mediator results in multi-system broad-ranging symptoms of anaphylaxis, increased gastrointestinal smooth muscle contraction can cause crampy abdominal pain as in this patient. Mm, Vomiting, diarrhea, localized vasodilatation, and increased capillary permeability can cause skin and mucus manifestation. Localized vasodilatation and increased capillary permeability can cause skin or mucosal manifestation, including wheals, periorbital edema, conjunctival erythema. Often there may be cardiovascular hypertension, tachycardia, respiratory wheezing, stridor involvement. Management begins with prompt administration of IM epinephrine. Okay. Group A streptococcal pharyngitis can be complicated by acute post-streptococcal glomerulonephritis due to immune complex formation. When severe, mm, acute post-streptococcal glomerulonephritis can cause edema from fluid retention. However, unlike in this patient, hypertension is usually present and symptoms typically appear over days. Impaired bradykinin degradation can cause increased vascular permeability leading to facial or visceral angioedema, periorbital swelling, abdominal pain. However, this typically occurs with re-exposure to ACE inhibitor than the antibiotics. In addition, bradykinin-mediated angioedema, unlike muscle-mediated angioedema, does not cause does not cause rash or wheals. Bradykinin-mediated angioedema, unlike muscle cell mediated angioedema, does not cause rash. Okay. I can't see your screen. Yes, yes. Okay. This patient, this patient, this patient has likely overdosed on imipramine, ATCA, or overdosed of imipramine ATCA of the inhibitory, because of the inhibitory effects of TCA on multiple receptor types. Overdose Overdose can cause a variety of symptoms, including CNS toxicity. Overdose can cause variety of overdose can cause variety of symptoms, including CNS toxicity, unconsciousness, seizures, anticholinergic toxicity, hyperthermia, dilated pupil, intestinal ileus, flush, skin, hypertension, cardiac toxicity. Cardiac toxicity is caused by TCA inhibition for sodium channel in his Purkinje system and myocardium. This decreases conduction velocity, increase the duration of depolarization, prolong absolute refractory period, QRS prolongation, and ventricular arrhythmia, ventricular tachycardia, and ventricular fibrillation may result. A QRS interval more than 100 millisecond or ventricular arrhythmia in the setting of TCA. In the setting of TCA overdose is an indication for sodium bicarbonate therapy. Sodium, a QRS interval more than 100 millisecond or ventricular arrhythmia in the setting of TCA overdose is an indication of sodium bicarbonate therapy. Sodium bicarbonate likely improves cardiac toxicity through the following mechanism: it increasing serum pH, and the TCA less pharmacologically active, decreasing its avidity for sodium channel, increasing extracellular sodium concentration, raise the electrochemical gradient across the cardiac cell membrane, decreasing the impact of the TCA induced sodium channel blockade. Sodium bicarbonate infusion also improves TCA induced hypotension, which is caused by alpha 1 androgenic receptor antagonism in combination with cardiac toxicity is leading to cause and is leading cause of mortality in TCA overdose. Okay. Okay, I'm come. It is leukocyte addiction. This patient with recurrent, this patient with the recurrent non-purulent infection marked by neutropenia, recurrent non-purulent infection marked by neutropenia, most likely caused by leukocyte adhesion deficiency. Leukocyte adhesion deficiency is an autosomal recessive disorder characterized by reduced CD18 antigen, reduced CD18 antigen on the surface of the neutrophil, reduced CD18 antigen on the surface of the neutrophil. CD18 is a key component of the integrin which are required for neutrophil migration through vascular endothelium to the site of the infection. Because the skin and oral mucus are susceptible to bacterial invasion, leukocyte adhesion deficiency classically causes recurrent skin and mucosal infection, gastrointestinal respiratory tract pneumonia involvement can also be seen. Infection may be prolonged as seen in this patient are often life-threatening because neutrophil cannot travel to the site of the infection. The absence of purulence is typical and infectious fluid pleural effusion lack leukocytes. Other characteristics feature Other characteristics features of LAD include impaired wound healing, which can manifest as delayed separation of the umbilical cord, age more than 3 weeks, and delayed wound healing after surgery or trauma. The common pathogens in leukocyte adhesion deficiency are Staph aureus, as seen in this patient. In the gram-negative bacilli, characteristics lab finding include peripheral leukocytosis and neutrophilia because white blood cell cannot exit the blood vessel. Yes, the presence of giant cell granule within the neutrophil is pathognomonic for Shediac-Higashi syndrome. Shediac-Higashi syndrome, a lysosomal trafficking disorder characterized by recurrent albinism, and neurological abnormality. This patient has no hyperpig. This patient has no hypopigmentation and neutropenia would be expected. Albinism means almond color. Like, look at the, he's totally white. The, yes, whole body is white and eyes are white too. That is oculocutinous. Two, mainly the, if you look at the albinism patient, they are like, you need to differentiate from albinism and vitiligo. Vitiligo is like, uh, there is normal color and there is abnormal white color, but albinism, like almond is totally white. The almond, the fruit, what I am talking about, almond is totally white. This patient from head to toe is totally white. So first, and like, look at the eye. Yes, so there is whitish pigmentation, or like whitish sclera, not sclera, the surrounding. Yes, Hyperacute means immediate, like the liver transplantation happened now and now the patient has problem, like may not be, I am false. The outcome, hyperacute like outcome manifests less than 1 weeks after transplantation, and acute is less than 90 days. So he has infection. That cytomegalovirus is 1 to 6 months. Less than 1 month immediate acute. It is bacterial infection. Bacterial cause from operative complication, hepatic abscess, biliary leak. I'm reading the time frame. Okay. This patient, this patient underwent liver transplantation. This patient underwent liver transplantation 2 weeks ago and now has right upper quadrant pain, high fever, hypertension, tachycardia, and significant leukocytosis, suggesting sepsis due to an ongoing bacterial infection. Infections continue to the Infection continued to the major cause of morbidity and mortality in patients who had undergone liver transplantation. Length of the time since transplant helps categorize the likely infectious organism as follows: less than 1 month, bacterial causes from operative complication, hepatic abscess, bacterial causes from operative complication like hepatic abscess, biliary leak, wound infection, hepatic abscess, biliary leak, wound infection, or hospitalization, intravascular catheter intravascular catheter, external drain, months 1 to 6, opportunistic pathogen, cytomegalovirus, aspergillus, mycobacterium tuberculosis, in the setting of high-dose immunosuppressive medication. More than 6 months, immunosuppressants usually at immunosuppressant usually at maintenance level. Patients primarily at risk for typical community acquired pathogens at a higher rate than the general population. Okay, acute acute cellular rejection occurs less than 90 days after transplantation. Less than 90 days after transplantation and can cause fever, right upper quadrant pain, and elevation in the liver function test. However, this patient also has rapid onset hemodynamic instability, making a bacterial infection more likely. In addition, prednisolone can cause leukocytosis. Significant leukocytosis and high fever are more likely to indicate bacterial infection. Opportunistic infections such as cytomegalovirus, and Epstein-Barr virus are the most common 1 to 6 months post-transplantation in the setting of high-dose immunosuppressive regimen. This patient has rapid onset hemodynamic. This patient has rapid onset hemodynamic decompensation with significant leukocytosis 2 weeks post-transplantation, making a bacteria making a bacterial cause more likely. Okay. Okay. This patient whose ladder contacted an overhead power line become part of pathway of electrically traveling from power line to ground, likely entering his hands charred, insensate hands and exiting his feet, large open wounds on soles. In patient with high voltage electrical injuries, in patients with high voltage electrical injuries, tissue damage occurs from both the direct injury caused by electricity from the secondary secondary conversion of electrical injury to thermal injury, because bone with its high resistance to electrical current generates the most heat as current passes through the body. Thermal injury to internal structures surrounding bones, skeletal muscle often exceeds the visible injury to external tissue, skin. Skeletal muscle necrosis in patients with high voltage electrical injuries often leads to the following clinical features: acute compartment syndrome from intracompartmental muscle swelling, rhabdomyolysis with leakage of muscle contents, including heme pigment into the circulation, and heme pigment induced acute kidney injury, intratubular cast formation. Patients should be monitored for those Patients should be monitored for these conditions, should receive aggressive IV fluid resuscitation because of the risk of hyperkalemia, and from rhabdomyolysis, and potassium containing IV fluid should be avoided. Okay. This patient with bradycardia, diaphoresis, hypersalivation, meiosis, bronchoria, and with wheezing has signs of cholinergic activity. Most cases of cholinergic activity are due to OPC pesticide. However, the occurrence in multiple patients in a crowded city setting suggests intentional OPC exposure, possibly due to chemical weapon sarin, soman, soman. These agents have been used in multiple military and terrorist attacks. The gas is colorless, tasteless, and often has slight fruity odor. Organophosphates inhibit cholinesterase in the muscarinic and nicotinic cholinergic in the muscarinic and the nicotinic cholinergic synapses, leading to decreased acetylcholine degradation and overstimulation of the corresponding receptor. In addition, widespread increase in the visceral smooth muscle tone glandular secretion due to muscarinic hyperactivity. Nicotinic hyperactivity causes muscle weakness and paralysis that can lead to rapid respiratory depression and death. OPC poisoning can be confirmed by red cell acetylcholinesterase activity. Red cell acetylcholinesterase activity. Atropine, a competitive inhibitor of acetylcholine at the muscarinic receptor, can be used for both diagnosis and treatment. The presence of anticholinergic sign, the absence of anticholinergic sign might trias erythemus tachycardia after small dose of atropine 1 milligram support the diagnosis of the OPC person. Treatment usually require much larger dose. Further management includes palidoxime, a cholinesterase reactivating agent that treats both the muscarinic and the nicotinic organophosphates. Okay. This patient diphtheria, the DPD diphtheria treated as acellular pertussis vaccine is combination vaccine containing acellular pertussis antigen with diphtheria and tetanus toxoid. Combination vaccines are safe, effective at preventing infection, and beneficial in reducing the number of needle sticks required, reducing in decreased pain and improved compliance. Children should receive 5 doses of inactivated DTaP vaccine at age 2 4 6 months, 15 to 18 months, and 4 to 6 years. The risk of adverse reaction to DTaP vaccine is low and generally include minor erythema, swelling at the injection site, and fever. Seizure triggered by fever or Seizure triggered by fever or by pertussis vaccine component is rare and is typically short, less than 5 minutes, and self-limited as in this child. Patients with family history of febrile seizure or epilepsy may be at increased uncomplicated may be at increased risk. However, neither personal nor family history of seizure is a contraindication of immunization, especially uncomplicated seizure following vaccine administration is not a contraindication to future vaccination. The benefit of a DTaP vaccination, especially in the setting of pertussis outbreak, outweighs the unlikely risk of significant side effect. The DTaP vaccine the DTaP vaccine is contraindicated in the DTaP vaccine is contraindicated in a few circumstances when anaphylaxis develops following DTaP administration. The patient should not receive the future doses. In addition, unstable neurologic disorder, infantile spasm, uncontrolled epilepsy, and the encephalopathy, coma, decrease level of consciousness, prolonged seizure within a week of DTaP vaccine within a week of DTaP vaccine administration are contraindication to the combustion vaccine. As a result, diphtheria and tetanus toxoid should be administered without pertussis. Okay. Okay. Benzodiazepine may be used in the management of bipolar disorder, insomnia, seizures, and alcohol withdrawal. Benzodiazepine can be used in bipolar, insomnia, seizure, and alcohol withdrawal. However, risk of overdose, physical dependence, and withdrawal make temporary use more desirable than alcohol than chronic administration whenever possible. These patients slur speech. These patients slur speech, ataxia, and CNS depression, lethargy, drowsiness are consistent with benzodiazepine overdose. Benzodiazepine are sedative hypnotics with stereotypical features of intoxication. Mild to moderate CNS depression, ataxia, slur speech, as in this patient. Severe is respiratory depression, arrest, hypotension, hypothermia, or coma. CNS depression is the most common symptom in benzodiazepine overdose. CNS depression is the most common symptom in benzodiazepine overdose. Respiratory depression may occur, however, this generally happens after a large overdose or rapid IV administration of short-acting formulation. Associated co-ingestion with CNS depression, opioid alcohol generally increase the risk of respiratory depression and death. Co-ingestion. Okay, what are the findings in here? Like how you diagnose that it is benzodiazepine overdose? Mhm. Yes. Okay. Yes. NMDA antagonist PCP ketamine clinical feature is violent behavior, dissociation, hallucination, amnesia, nystagmus, ataxia. So NMDA antagonist causes PCP, ketamine causes this. MDMA ecstasy can cause euphoria, tachycardia, hypertension, hyperthermia, serotonin syndrome, tachycardia, hypertension, hyperthermia, serotonin syndrome, hyponatremia, seizure, and mydriasis. And benzos, CNS depression, normal vital signs, slur speech, ataxia, coma. And opioid narcotics, there may be euphoria, decreased mental status, respiratory depression, meiosis, and constipation. Okay. Okay, these children who are typically exposed to lead through inhalation or ingestion of lead particles from their environment. They are at increased risk of lead poisoning compared with adults to an incomplete blood-brain barrier, increased mouthing of subjects in their environment, and increased GI absorption of lead. A risk factor for elevated lead poisoning. A risk factor for elevated lead levels in is living in a home built before 1978. Especially there is being especially there is spilling paint or dust released during renovation. Other risk factors include lead piping. Patient lead piping having a parent who works with batteries, having a parent who works with batteries or pottery, or having playmate sibling with a history of lead poisoning. Patients who are symptomatic from lead toxicity. Patients who are symptomatic from lead toxicity can have anemia, abdominal pain, encephalopathy. Targeted screening of high-risk population regardless of symptoms is important, as most children with lead toxicity are initially asymptomatic but can have cognitive and behavioral problems that can become apparent after school entry. Capillary blood specimen, capillary finger sticks blood specimen are widely used in the screening of lead poisoning, false positive results are common due to environmental contamination and improper collection. Confirmatory venous lead measurement is required to confirm the diagnosis of the elevated lead level. If a screening capillary lead level more than 5 microgram per day. Okay. Okay. This patient. Okay, I have a question. Like in thalassemia major patient, okay, apart from repeated blood transfusion and apart from like chelating therapy, is there anything else we can give? Like, is there bone marrow transplantation? Is there any role of bone marrow transplantation? Yes. Okay. Okay, I'm thinking, that's why I asked. Okay, this patient has had streptococcal bacteremia, Giardia lamblia, and recurrent sinusitis as well as failure to thrive, asthma. His presentation is most suggestive of common variable immunodeficiency disease. In common variable immunodeficiency disease, abnormal differentiation of the B cell into plasma cell, abnormal differentiation of B cells into plasma cells, resulting in decreased production of multiple immunoglobulin classes. CVID CVID presents in adolescent around puberty and or young adults 20 to 40 with recurrent sinopulmonary infection. Patient frequently from encapsulated organisms such as Streptococcus pneumoniae, Haemophilus influenzae, chronic pulmonary disease, asthma, bronchiectasis is common. Patient may also have recurrent diarrheal infection, Salmonella, Campylobacter, Giardia, and failure to thrive. Okay, there is stem cell transplantation or gene therapy. Okay, bone marrow transplantation. There is an option. Okay, yes. Okay, we know the CVID. We can move the next. Okay, the last line is very important, like 100% oxygen fails to increase the pulse oximetry reading or the cyanosis. Okay, it's methemoglobinemia. Look at the box first, exposure to oxidizing substance, and dapsone nitrate, and topical anesthetic. So this person got topical anesthetic when she got toothache. Okay. Results in cyanosis. Additional clinical features may include lethargy, respiratory depression, seizure, and death. In normal, hemoglobin iron is the ferrous state when iron is a ferrous state when exposed to an oxidizing agent. When exposed to an oxidizing agent, at least one of four iron molecules is oxidized to ferric state, results in acute methemoglobinemia. Ferric iron is unable to bind with oxygen. In addition, the ferric state changes hemoglobin structure causes ferrocite to have increased affinity for oxygen. The left shift on oxygen dissociation curve. The increased oxygen affinity prevents oxygen release in the peripheral tissue, decrease oxygen delivery. So because methemoglobin absorb light in different wavelength from hemoglobin, patients have pulse oximetry reading 85% regardless of true oxygen saturation level, as seen in this patient. Supplemental oxygen has no effect on the altered supplemental oxygen has no effect on the altered methemoglobin structure, and therefore it does not improve the cyanosis, blood color, and pulse oximetry reading. In contrast, arterial blood gas testing analyzes only unbound arterial oxygen as opposed to hemoglobin bound oxygen, and displays a falsely elevated oxygen saturation level shown as normal PO. Okay. PaCO2 increases in respiratory failure, as such as in severe bronchiolitis or asthma. In a tachypneic individuals with a healthy lung, as seen in this case, PaCO2 will be low due to hyperventilation from tachypnea. Okay. And B. Okay. An elevated plasma osmolar gap is seen after methanol or ethylene glycol injection. Methanol or ethylene glycol injection. Patients with uh, condition may have signs of alcohol intoxication but are not silent. Okay. Yes. This patient has methemoglobin medical emergency. Any medication topical anesthetic suspected to be the cause of methemoglobinemia. The antidote is required. So the antidote is for acquired Symptomatic methemoglobinemia or high level of methoglobin measured by co-oximetry is methylene blue. Methylene blue acts as an electron transporter. Methylene blue acts as an electron transporter for NADPH and is reduced to leucomethylene blue, which in turn reduces methemoglobin to hemoglobin. High dose ascorbic acid acts as a reducing agent and can be used when methylene blue is unavailable or contraindicated. Glucose 6-phosphate dehydrogenase deficiency. What is methylene blue? I haven't seen in my life. So we just tell the patient to eat. Okay. Yeah. Yes. Yes. Okay.